دكتورة.
تفضل دكتور.
Yes, okay. Now, I will continue talking about personalized oral hygiene program for elderly patients. For elderly patients with poor manual dexterity, proper monitoring by the caregiver is needed, and more frequent visits to the dentist. Also, the patients need to minimize the sugar intake and use products that contain fluoride, use a rotating toothbrushes, and clean between the teeth regularly using a breath-threaded flosser or water flosser. م- ماشي. And he may also use interdental brush, and these
The sound went away. Can you just repeat?
patients with dry mouth.
Can you please repeat? The sound went away for a moment.
Okay.
The
Okay.
last couple of minutes.
For patient, okay, Doctor. For patients with poor manual dexterity, or for elderly patients with a poor manual dexterity, proper monitoring by the caregiver is needed, and more frequent visits to the dentist. Also, the patient should be instructed to minimize the sugar intake and use products that contain fluoride. Also, he may be instructed to use the rotating toothbrush or the electrical toothbrush to aid him in teeth brushing. Also, they should be instructed to clean between the teeth regularly using breath-fed flosser, interdental instruments, or water flosser. These instruments makes cleaning interdentally easier for patients with poor manual dexterity compared to the conventional flossing. Now, for patients with dry mouth, precautions should be taken, including drinking a plenty of water and the use of artificial saliva products when necessary. And more frequent toothbrushing or rinsing should be encouraged in those patients. For patients with denture, the denture hygiene measure should followed, including brushing of the oral mucosa and tongue twice a day with a soft brush, clean dentures after meals to remove food and plaque, clean dentures well using a denture cleanser and a soft toothbrush. Avoid dentures wearing overnight. And when the patient is not using the denture, it's important to keep the denture clean and hydrated in a container. Finally, we should encourage the use of single tuft brush around the abutment in the cases of implants or tooth-supported overdentures. And thank you.
Thank you indeed, Doctor. If you can just give me the control so I could, inshallah, comment on your presentation. Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Doctor, for your presentation. It was very interesting. I love the work where you have worked and talked about the assessments and how do you assess their abilities. Okay, so you first worked with functional needs. You talked about the functional needs. We know about ages. Simply, it's easy to classify elderly by their age, but by their functional needs and as well as their changes, this is very good, especially the cognition, because the psychology of those that are elderly is very different from that of the patients that are young and cooperative with you. So the cooperation with the geriatric patients are directly related to their cognitive abilities and how much they trust you. So they can shift from a very difficult patient to a very, let's say, a patient that really trusts you and would take anything that you say as a must. So the classification of their cognitive ability in terms of classification of patient difficulty I would love you to add it here, okay? The classification, we took in general complete denture books, so the classification of patient difficulties. It's because those are related to their age. The changes in oral mucosa, the changes in saliva flow, I love these. But here I would love to see the following, which is the change and supposedly here, for example, if you can, how is this relevant to our work? For example, you have a dry mouth. Is this relevant to our work? What would you change because of the xerostomia? So if you can add a bit some applications, it's not only what are the diseases related to it. How do I change my work? For example, if I'm going to place a cotton roll in a patient that are elderly, when I want to take it out, I just simply wet it because there's not enough saliva to wet it, and it will drag the tissue with it, and it might cause some ulceration. It's as simple as that. Things about how the patient, when you put a denture in, you have to wet the denture before putting it in. Some applications or some tips or some practical changes. Well, how do you change your regular day-to-day practice if you're doing it with an elderly? So the effect of the saliva, you change stuff, the effect on oral mucosa, for example, how are you going to deal with this dry mucosa, this thin mucosa? How you become more careful when you're doing any instrumentation inside the patient's mouth because the mucosa is vulnerable. The teeth, if I'm going to do endo, I might expect so and so and so, and the elderlies. Just mentioning them, how do they affect your treatment if it was a regular case or not? In terms of caries, you presented it very well. Periodontium as well. Just some practical tips based on this. You talked about oral health problems, and you talked about how they work and the cognitive assessment. I was putting that in my comments, but you have explained it well. But there is something that you haven't explained, which is the manual dexterity. Because of the neuromuscular control, they lose the neuromuscular regulation that they have. So they want to do a movement, but they are not able to do it. Have you tried that? You tell a patient, a geriatric patient, to open the mouth and move from left to right, and they could not perform that function? You have passed like that.
Yes.
So they understand you. Sometimes the cognition is there, but the ability to translate it into an action due to the poor neuromuscular control causes them some difficulties. Sometimes when if you're asking them, by the way, like, where's the pain, they would sometimes put their hand on the upper, and while the pain is in the lower, they even could not manage to put their hands on the exact place where pain is. So mentioning the neuromuscular, the loss or the reduction in neuromuscular control, it's not the cognition ability that is reduced, it's the neuromuscular control. It's something similar to what you will have, for example, in our ages, in any age, usually in the back, for example, if somebody is scratching somebody else's back, what would they say? Move a little bit more to left and right. But you're moving like centimeters, and you have not reached where they are intending you to move. This is because the concentration of touch and the neurons of touch in the back is very, very low. So this happens even in the areas that are regularly well innervated by these neurons. For example, the face, the hands, these are the very sensitive areas to trauma. So they are usually very specific in their neural control. So these abilities in the patient, they lose that fine neural sensation because of the aging effects, okay? So all of this should be taken into account. So if there are some applications about the neuromuscular control, and this is, by the way, when you are talking about the last bit of the last slides, when you're talking about the instrumentation in the side of the mouth, when the patient is cleaning for himself, if you have noticed that for the elderly, they put handles that are large, for example. The toothbrush has a large handle because of this weakness they have in their muscles. So to have a good grip is a problem. Also, this also affects the setting of your clinic if you are dealing with the geriatric patients. For example, geriatric patients, they have because of this low neuromuscular control, if they fall down, they are not able to produce that reflex that protects them from having any problems. So when they fall down wholly. They don't have the reflex where they put their hands first, for example. So that means that your clinic should have wide entries. It should have no furniture in the intervening. Their visual accuracy is low, so you don't place. You use more color contrast with your furniture, so the patient could realize that there is a step here or not. For example, some people paint the edges of steps with yellow, for example, so that the elderly would notice that there is a step here. They would not notice it if it was the same color, if the ground and the stairs were the same color. So all of these are some things that you do in your clinic to accommodate geriatric patients. Even the parking, you have to have parking for the elderly. You might have access for wheel shares. So all of these are included in geriatric care. So if you add a little bit about these, and these are all related to the poor neuromuscular control and adapting to their visual and hearing needs because of this, because of the aging process. Okay, you talked about saliva substitutes, but I would like you to go deeper in this subject. Saliva substitutes is an important issue because it goes together with the water intake. In general, their water intake is less, all together with the food, and also it goes with the xerostomia case, and it goes with all of the functions of saliva. So saliva substitutes are a big issue. So I would like you to put a review or a systematic review, if you can find, about the saliva substitutes themselves. Okay, because those are a big issue in their work. So it's the ergonomics, the saliva substitutes, the dental settings, as I told you, changes in dental settings, caregivers' roles. Okay, so even caregivers, they have roles when we're dealing with geriatric patients. How do you communicate with them? How do you take consents from them? So the issue of consent is important here. So if you could give more on the consent taken from elderlies, it's similar to the subject when you took pediatric patients. How do you get consent from a pediatric? You take it from their caregiver, okay? So something about consents, something about appointment arrangements, something. So the role of the caregiver in geriatric patient management, okay? So those are the people that go in to give you the appointments. Those are the people that will be transporting the elderly to your clinic. Those are the people that will be applying your instructions and your verbal communication. Okay, those are the ones who will sign on, for example, shade selections and so on. So they have more authoritative work that you could go. So adding that bit is very important. Finally, you should not exclude those in nursing homes. How could I serve those in nursing homes and those in hospices? The nursing homes are those that have institutionalized. It's an institution that governmental usually that they stay there like with all their caregivers are usually employee, not family members. There are differences between when the caregiver is a family member or they are an official, let's say an official officer or something like that. So when they are institutionalized, you can go for visits there. So what do we do in visits? What are the types of care we provide at location? It could be by the way home visits as well. Some patients you provide home visits. What are the types of dental care that you provide in home visits or into institutional visits or in even oral health programs? Because there are some oral health programs dedicated for those groups. And finally, we're talking about oral health institutionalized. Okay, hospices. Hospices are those places where people are usually very terminally ill. Okay, so what are the type of oral care? This is where I'm concentrating. They have a lot of body care. I don't want that. I just want to concentrate on hospice oral care giving. Just mention what are the care procedures that they are given to those in hospices. When are they allowed to wear dentures? When dentures become a hazard for them because it might suffocate them or so on. So try to mention hospices because those are another group or community that oral health provision is given. Okay. So these are more
Yes.
comments.
Yes.
Thank you very much. It was an interesting lecture.
Sarah, again,
Yeah.
the name that you mentioned,
Which name?
again,
Hospice.
yes.
Hospice is the place. It's usually where they take care of terminally ill people. They're not regular people. They are terminally ill. The type of medications, the type of devices, all of the care is given for them, waiting for them till their last days. So they are usually terminally ill patients with last stage of cancers, and so on. So they have a special area to care for them. They are not regular hospital residents.
Okay. So they are not just for old people, elderly people, or geriatric patients.
Usually, let's say if you would go in, like 9 out of 10 would be elderly, terminally ill elderly patients.
Okay.
You might find some a little bit younger, but it's not usually caring for children, of course. The hospice is usually for the elderly that have the terminal diseases.
Okay.
Okay.
Yes.
Okay. Fine, Dr. Abdullah.
Fine, Doctor.
Okay. As I told you, as I always say, the adjustments, as I told you, first look for any systematic review talking about the subject. Just mention, just highlight and open the windows and bring about the questions. And usually those of us that will be working with those groups, or anybody who hears this when we place it on YouTube, you should have opened some windows in their mind where to be thinking about and going and explore more. How can they provide this care better? So it's just mentioning it is enough for us, for our purpose, that there are specific areas that you should be thinking about when you're talking about geriatric patients. Okay?
Yes.
So thank you indeed, Dr. Abdullah. And see you in our last presentation next Thursday, inshallah. Assalamu alaikum.
Inshallah. Thank you, Doctor.